Welcome, everybody. We're so glad you could be here this evening. Dr. Vyas, why don't you go ahead and introduce yourself first?
Sure. So I'm Dr. Nina Vyas. I'm a reproductive endocrinologist at California Fertility Partners. We, at our center, we really see a lot of third-party reproduction, including surrogacy. And I think, anywhere really in California, especially Los Angeles, since it's such a surrogacy-friendly state, we do see a high volume of those types of patients. And so we've really developed this nation helping guide the medical clearance process, really vetting out exactly what makes a good surrogate, what think pitfalls to kind of look out for. So, in conjunction with our colleagues at our services, at the consult agencies and consulting services, like you have, Jesse, I think working hand in hand is really important for intended parents and surrogates to know that they're getting a good experience and trying to make it as painless as possible. And I know it could be rather painful, but you know yourself, personal experience.
Yes, absolutely. I'll share a little bit about me. I'm Jessie Jaskolski. I am a surrogacy consultant and concierge. I'm a former intended mother myself through surrogacy. I had a 22-week pregnancy loss that left me with secondary infertility, which was what the catalyst was for pursuing surrogacy. And it really just changed my life so much that I felt like I needed to stop what I was doing quite literally and help
Mhm.
other people on their journey because I just felt like the process is so overwhelming and I wanted to find a way to make it easier for people to navigate. Okay, so here are some of the topics that we're going to cover tonight. And of course, at any point, you can jump in with questions. We want this to feel informal and just really hope that you get a lot of value out of it. Okay, I kind of went through this, but this is me with my two daughters that just really are such my miracle babies and are what led me to launch my consulting firm.
They're beautiful, Jesse.
Oh, thank you. Thank you. A few acronyms before we begin. I couldn't stop myself from a Schitt's Creek reference. Um, IP is intended parents. GC is gestational carrier. IF and IM is intended father, intended mother. Interestingly, when I was going through my surrogacy journeys, I didn't want people to call my surrogate a surrogate. I wanted them to say gestational carrier because I wanted them to realize that we had my daughters had a biological connection with me. Fast forward now, almost 5 years later, surrogacy is being talked about so much more, Dr. Vias. I don't know if you're noticing this too. I feel like
Hmm.
people are really just saying gestational carrier and surrogate interchangeably. Even my comfort level with using them
Yeah.
interchangeably, it's so interesting because that doesn't feel like that much time at all.
Hmm.
But
Hmm.
now I really do feel like people say surrogate and everyone kind of knows you're referring to gestational surrogacy, which is when the surrogate does not have that biological connection to the baby.
Yeah, and I'm so glad that you mentioned that because when we were prepping for this talk, I actually made the same slide with distinguishing the difference, but then you
Oh,
already
good.
had it in here. But I think it's so interesting because I feel like when you're in the field, you know that there's a difference actually, but I think like you said colloquially now, I think the baseline understanding is that a surrogate is more like a gestational surrogate. They're not somebody who's using their own eggs to help facilitate this pregnancy. So, I think it is being used interchangeably now, which I'm okay with as long as people kind of understand. But of course, as the intended mother, like you said, you wanted to make it clear. And so I think that's a nice little point of education for the people who are in your circle as well.
Yeah, absolutely. So there's three ways to manage the surrogacy journey. I'm going to start with an agency. An agency is best known for matching intended parents with a gestational carrier. Each agency is going to vary a little bit in terms of what their services offer, but generally speaking, they're going to help you with case managing the journey. Independent is like on the complete opposite end of the spectrum. And a lot of people go to the independent route because you can save a lot of money. Of course, as we know, and we'll get into cost later on this evening, it's quite expensive. On an independent journey, you will have found a surrogate yourself, whether it's somebody you know, a family member, a friend, or if you've used social media or another platform to find a surrogate, and then you manage the entire journey on your own. A consultant and concierge There's all different types of consultants. Some consultants work with you just to find an agency. Some consultants give you initial advice. I'm going to explain a consultant and concierge in the way I use it. And for me, I'm almost a hybrid between an independent and an agency assisted journey. So for folks that know somebody that's going to carry for them, I would the type of consultant I am, I still guide and do all of the case managing and all of the emotional support and guidance that they would get from the agency. And for those that are using an agency, I help them decide what's a priority, whether it's cost of the agency, time to match, location of the surrogate, and I help them select an agency. And then from there, stay with them throughout the entire journey to make sure all of their needs are being met. So for ways to find a surrogate, and that's a picture of me and my first gestational carrier that carried my oldest daughter. You can use an agency, social media. When I say social media, I'm primarily referring to Facebook, and there's lots of private Facebook groups where you can post a little bit about yourself and find somebody. More recently, there's more different. I see more people using Instagram also to connect. And I'm also seeing more matching platforms pop up, which is interesting because as I shared when I personally went through this, the matching platforms were not available yet, and things keep changing. And there's platforms like Nodal and Expecting AI, and you can think of them almost like a dating website where an intended parent is matching with a surrogate, and then from there you're sort of guiding yourself on the journey. Some people are lucky and they have a family member or a friend that comes forward and is willing to carry for them. And other people have leveraged social media and not only joining the private Facebook groups, but going back to a friend, they've posted a status and other friends have shared it. And then sort of like their web has expanded. So, like, it was like a friend of a friend that came forward. And I've had a lot of clients have success with that way as well. Okay. This is a picture of me with my second surrogate who carried my almost 2-year-old daughter. I'm really passionate about the matching process because I think it really just sets the tone for a beautiful relationship. Things to be thinking about are personality, communication style, and preferences. For me, as I shared, I came to surrogacy following a pregnancy loss. So I knew it was really important to be matched with a surrogate that wouldn't mind frequent communication, not in stage 5 clinger way, but in a way where I was hoping for a friendship to develop. And I believe that since I was so transparent about what I was looking for, I was able to match with a surrogate that had similar expectations. And now I remain in contact with both of them and we have beautiful relationships. For my next point, I always make the joke that things that you don't want to talk about at a holiday meal, these are the things to talk about with your surrogate because I don't want you to fall in love with somebody and then get to the legal phase and realize that it's not a match. So when I say hot topics, be thinking about things like vaccinations, termination, compensation, how many times you're willing to try if the first or second embryo transfer should not be successful. We want to make sure they live in a surrogate friendly state. I talked a little bit about the relationship, but I do think this is a great opportunity in the matching phase to think about how you're going to talk to your future children about this. If you want the surrogate to be in contact after the birth, if you plan to be a yearly update, what that's going to look like, and sharing some of those expectations. And sometimes it's even okay to say, I don't know. I want to meet you and see how things progress. And then, of course, this one's a little bit more boring, but meeting your fertility clinic requirements, which is, of course, something that's so super important because we want to make sure that they meet all the expectations and are able to carry.
Boring, but where I come in.
It's just more of like boring in that it's like the list of criteria.
Oh, yes, I understand. I definitely get it.
Okay, so onto the surrogacy process. I'm gonna kick it over to you, Dr. Vyas, and we're gonna jump in at certain parts, but the first one is embryo creation, and I believe our next slide talks about that a little bit more.
Exactly. So, of course, you kind of have to say it out loud, but it's implied, right? If you're transferring, if you have a gestational carrier or a surrogate, they are going to need to have embryos to transfer into them. And how we get those embryos differs in everybody's journey. So with a gay male, two male couple, you need an egg donor at some point, and then decisions on where the sperm source will be. Sometimes it'll be splitting the eggs from both partners, and that could be how we get our embryos, and then making a decision on which embryo to transfer first. The In a heterosexual couple, making the embryos kind of through kind of conventional IVF with the intended mother and the intended father's genetic material. But the caveat to all of this is that, the embryos must be made with FDA compliance. And I guess this is what you're talking about with the boring stuff, but it's,
So
that's
important.
just yeah, it's so important, and it's the law, and it seems a little bit redundant, but unfortunately, none of us can really get away from it. FDA compliance is actually really straightforward and simple, but what it really means is that at the time that you give the or during your IVF creation cycle, within 30 days of an egg retrieval for a woman or the egg donor, and within 7 days of giving the sperm for the embryo creation, the male and the female partner must have a physical exam done, answer a medical questionnaire rather detailed about their social habits and their medical history, laboratory testing for routine sexually transmitted infections, but this just has to be done through an FDA approved lab, genetic screening, because of course you want to know kind of at the get-go, especially if you have an egg donor or a sperm donor involved in the embryo creation process, that there's no overlap in the genes between the donor and the intended parent, not necessarily the carrier. Legal consultation when you're creating the embryos, especially if we know that it's being used by a donor, in that process, and then a psychological consultation. So you mentioned kind of that you're part of that emotional support for these couples as they're going through this journey, and this psych evaluation is not to determine whether or not you're fit parents, right? That's not the point of the psychological evaluation. It's more about what you said about, what is our game plan about what we're going to tell this child? What are we telling ourselves? What are we telling our families about how we're going to navigate this process? And it really helps increase your vocabulary. That's the way that I found it to be helpful when I was kind of part of this process myself. It expands your vocabulary to things that you didn't really understand. You've never thought about putting in your vocabulary. Like what are you to this person? You're still their mom. You're still your daughter's mom, and somebody else helped you have them. So that's the kind of the benefit of the psychological evaluation, is not the evaluation, but the consultation, is to help with navigating that and having somebody to touch base with when tricky situations come up, kind of for the rest of your life. In many
Yeah.
ways, when you're using a third party. Yeah.
And something that I was thinking about as you were talking about the FDA compliance that I think would be interesting for people to hear about is sometimes embryos are created and you think you're going to transfer to yourself and you don't foresee
Hmm.
that there's it's going to turn to needing a surrogate. And
Yeah.
I know this can vary a bit depending upon the clinic. I know some people do a retroactive FDA compliance. I'd love to hear your thoughts on that
Hmm.
and how you handle some of that.
Yeah. So it's generally actually this came up today for me in a consult. So,
Yeah, it's an
the,
interesting question.
yeah, the easy answer is that there's an FDA waiver that you sign, right? And almost every clinic that we've ever worked with, or that you should ever work with, is doing infectious disease testing at the time of embryo creation, whether it's through FDA compliance or not. They're having infectious disease testing done. And that's at maximum 2 years from when they create their embryos, right? We always want to make sure their infectious disease testing is up to date. So if you understand that there's, maybe somebody had their infectious disease testing done 6 months before their embryos were created, um, and this carrier understands that risks that maybe something could have developed in the interim, then that's okay. You just have to sign an FDA waiver. Some people then, like you said, will, if it's been, for me personally, if it's been over a year since the embryos were created, from when their infectious disease testing was done, I would just recommend that they just get retested. Why not get retested, have peace of mind, before transferring the embryo into the surrogate? And then, everyone can be at peace of mind as well, just knowing that you're transferring your genetic material into somebody else.
Great, thank you.
Hmm.
Okay, so next would be in our process would be matching with a surrogate. And we talked about this a little bit. So, ways of matching that we shared were again using an agency, a friend or family, using use of social media, and matching platforms. And now it is back to you to share a little bit about what you're looking for specifically in terms of medical records, because the next step is typically that we send the medical records over to the fertility clinic for approval.
Yeah. And the medical records are very thorough. So, I mean, ideally, they're very thorough, and we want to know exactly what's in them. And so, some of the things that we look at when we're looking to choose a carrier, the ASRM criteria is kind of listed on this one side, but just recommendations the carrier should be between 21 and 45 years of age. They should have at least had one term uncomplicated pregnancy before being considered as a carrier for another couple. Ideally, kind of this one is where this gets brought up a little bit more. How many previous deliveries, can your carrier have had? And so the ASRM recommendation is that there should be no more than 5 previous vaginal deliveries or no more than 3 previous cesarean sections. So that would mean that your pregnancy could be their sixth vaginal delivery or their fourth C-section, but it's worded a little bit interestingly. And the reason for that is that I know some people kind of wonder why, and I'm it's just still so ingrained in me from when I was a resident as to why these things matter. But I think it's worth saying out loud too, right? Like, so the increased number of vaginal deliveries you have, even though, they're quote unquote vaginal deliveries and they're not surgeries, every pregnancy that you have is quite a toll on the uterus. And the uterus is a muscle, and the muscles get lax after some use. So, as your number of pregnancies increase, your risk of things like preterm delivery, breech presentation, postpartum hemorrhage, and with all of those things are associated risks to both the carrier and the baby. And so that's why it's not recommended to have more than 5 previous pregnancies. For C-sections, that C-sections are hard. They're tough on the body, right? They're really tough on the body. And it's major abdominal surgery, and one of the only ones where you're required to take care of a human being right afterwards, and in this case, you're not taking care of the human being, but you still have to recover from your cesarean section. And it's a big incision through your uterus. And so every time you make a cut through the uterus, that area is getting thinner and thinner. And so it increases your risks of two main things kind of come to mind. One is things like placenta accreta or adherent placenta, so they can adhere to the actual scar, and that makes removing the placenta after the delivery much more dangerous. And then, secondly, um, things like uterine windows. So all those that area that you're making repeat incisions to actually do the C-section, the area of your uterus actually really thins out, and that can cause uterine rupture. And of course, I'm thinking about worst case scenarios, but we should be, right? We should be thinking of worst case scenarios when we're doing a medical clearance of a gestational carrier, especially because we're transferring this precious embryo into somebody of yours that you've worked so hard for, and also to keep these really altruistic people, our carriers, safe and healthy. And so we should be extremely picky about it because we have to, the goal at the end of the day is healthy mom, healthy baby, a healthy carrier, right, in this situation. So that's why we're so picky about it. Um, so I spent a lot of time on that bullet point, but I do think it warrants a bigger discussion. And then, of course, the carriers have to have a stable family environment with adequate support. And oftentimes, carriers are single mothers themselves, and so a lot of the records that we review are single mothers, but they're incredibly well supported by their families and their sisters and their neighbors and so on. But it's just good to know who's going to be the person who your carrier can rely on, because pregnancy is challenging. And so we all need our village around us when we're pregnant, whether it's for ourselves or for an intended couple. And then other
Absolutely.
considerations, yeah, when I'm reviewing medical records, I'm always considering BMI, because obesity is unfortunately, uh, running rampant in this country, and there's a lot of health implications when it comes to pregnancies and obesity. So BMI is a really big part of that for me. Our personal cutoff at CFP is somewhere around 31, a BMI of 31. And if it's over 30, we recommend attempting weight loss. But we really, we know that women can do it. It's hard, but we know that women can do it and hopefully bring it down below 30. any sort of previous cervical or uterine procedures, right? How they had a septum, or since their last journey or their pregnancy, maybe they had a LEEP or a cold knife cone for cervical dysplasia, and that could impact the health of the future pregnancy. If it's a first time surrogate or an experienced surrogate, and there's two sides of the coin there. Yeah. So the first time surrogate is probably going to have less pregnancies, so less of those risks that we just talked about. But having an experienced surrogate does have a lot of benefits as well. They know how to navigate the system. You know that they've done this before and they've done it well and they've done it properly. Taking all those injections isn't easy, and going to all those appointments and all the crazy things that we put them through as fertility clinics, it's not easy. So there's two sides to that. So that's something else we consider when I'm chatting with my patients about who to choose. Prior deliveries, like we mentioned, and any associated complications like preeclampsia, growth restriction, diabetes, placental complications. And then another interesting one is, are they willing to carry twins? And I think from most of the match sheets that I review, most people are willing to carry twins if the embryo splits. But if there are clinics that will transfer more than one embryo, is that something that your surrogate will do? That's not something that we do routinely at CFP, but just something else to kind of keep in mind. And then COVID vaccination status as well. Most people, I would say, would want a vaccinated surrogate, but there's some intended parents out there that don't, and that's not in their belief system, so that becomes a little bit more tricky, but things to consider.
Absolutely.
Mhm.
So next up would be the psychological evaluations, which we already spoke about. And I will just add to that the gestational carrier also receives a psychological evaluation and her partner. And as I've been working with people, I've actually learned that I had a group session. So each, the intended parents have a psychological evaluation, the GC and her partner do. And depending upon the state and the fertility clinic, there's sometimes also requested a joint psychological session. I
Mhm.
really recommend this because I think it's really valuable to be there all together with a neutral third party to discuss different topics and different potential issues that could arise.
It's a great idea.
Yeah. Do you require that?
We don't require a joint one, no.
Yeah.
Just individual, but that's a great idea and something that we should definitely offer to patients at least.
Yeah, it's so interesting that every state handles that piece a little bit differently. But I
Mhm.
always say to my IPs that even if the clinic doesn't, it's a really great idea.
Yeah.
And then the next is the actual medical evaluation day. And I do want to just, before Dr. VS goes into that, share that the exact order might vary a little bit depending upon your type of journey. So, for example, if you're working for an agency, they might have already sent the medical records and had them pre-approved prior to a match call. So there is some variation in what the process looks like depending upon your journey. But at least at the end of this presentation, you'll have an overview of the lay of the
Mhm.
land and all of the different things involved.
Yeah, that's a good point. So at the medical examination, once the records have been reviewed, there is, the hopes that this will be the match before legal. Usually, they'll come in for medical clearance, and so medical clearance is really just, we're doing the physical exam on the patient, or on the surrogate, and then we're also mainly the main goal is to look at her uterus, right? We want to see what the uterus looks like. So if you can click to the next slide, Jesse. The way that we do this the best is by doing a saline infusion sonogram. And I would say almost always your intended parents REI will want to do this themselves. There are some cases where, we'll allow this to be done at an outside practice, or, someplace more locally to you. But essentially, we want to do it ourselves because it's our precious embryo that we worked so hard for, that we're putting back in. So definitely at CFP, we love to do this ourselves. And what we're looking for is what's going on inside of the cavity. So if you think about a uterus, that picture on this left side is kind of a good example for what I'm going to demonstrate. But the uterus is like a deflated balloon that hasn't been blown up yet. So the sides are kind of stuck together, and you can't really see what's going on a regular ultrasound. When we distend it with saline, so now we're starting to blow up the balloon, we can now see what's going on inside, like the black is fluid. And so now we're able to see, wow, like inside of this cavity that's beautiful, it's pristine, there's nothing else that looks like it's out of place. So this is what we would say is a normal saline infusion sonogram. medical clearance checks out as long as all the blood work looks good, and then you guys can move on to legal if everything else is in place. When we run into issues is what we'll see on the next slide here, which is on that top left, you see there's this like banding or a little bit of like that dark gray that could be from scar tissue from something like a previous C-section that could have some scar tissue that come, or from a DNC, from a miscarriage, etc. So things like that can come up. Oftentimes we also see that with myomectomies or removing fibroids, but that's something that would have come up during the medical record review and probably been deemed not to be a good candidate if the surrogates had fibroids removed in her from her uterus. On the bottom are polyps, and these are easy things to remove with hysteroscopy, but definitely that polyp and the fibroid on that right side and that right picture are exactly where we would transfer the embryo. So we don't want to. We want to make sure that that's removed before we would transfer that precious embryo there.
Okay, so the next step in the process is the legal contract. And I think some of the key points to take away on this part of the process is there's going to be two attorneys. The intended parents are going to be represented by one attorney, and the GC and her partner will be represented by another attorney. And typically, if you have a really good match and you talk about a lot of the hot topics up front, there shouldn't be too much back and forth in terms of revisions. And basically, the legal contract is in place to ensure the safeguards of the future baby, the GC, and the intended parents, and to make sure everybody is entering into an agreement. It talks about the terms of compensation, the disbursement, all of the what ifs, and really protects everybody, and is so, so important. And you cannot go forward until you've sent the fertility clinic not the contract, but a letter that says legal clearance has been obtained, because they're not going to be able to transfer an embryo until we've completed this part of the process. You will utilize an attorney later in your surrogacy journey as well. Depending upon the state, you might have a pre-birth order or a post-birth order. And that's typically, if it's a pre-birth order, it's around 20 weeks that you would start initiating that process. So not just yet. And then towards the end, once you've created your legal contract, it's created, it's executed, you will open escrow. And the point of that is to have your money safeguarded and then disperse to the surrogate by the terms of your legal agreement, and make sure that any other out-of-pocket expenses that she incurs, she's able to get reimbursed for. And then I will kick it back to you to talk about the preparation for the frozen embryo transfer.
Yep. So depending on kind of where by the time of the medical clearance, we kind of have a good idea. We're medically cleared. We know we're just waiting on legal. It won't take too much longer, probably a few weeks, while both parties really kind of evaluate it. Some people haven't started legal yet until the medical clearance is done. But I would say, what do you think, Jesse? Most people have legal kind of lined up and ready to go by the time they've
Yes.
done medical. Yes, because time
Yeah.
time is of the essence. So I would say, we know that within a few weeks we're going to have legal signed, and then we can get started with our transfer cycle. So I just put the option here for a medicated FET cycle, and in that sense for frozen embryo transfer, because we were talking about it before, medicated versus natural FET cycles for when you're talking about carriers. uh, Actually, I'll get into that in a second. Let's talk about this first. So, they essentially, when we see somebody on from their medical clearance, we'll know where they are in their cycle, in their regular menstrual cycle, and we'll make a plan for them for how we're going to start their embryo transfer cycle. We'll know, say, you're going to get your period in about 2.5 weeks, because we timed the saline sonogram to be like that. You'll get your period in about 2.5 weeks, and with the start of your period, we'll put you on birth control to help down regulate your own period for the surrogate, and then we kind of take over by giving estrogen and then progesterone, and then time out when we would expect to do the transfer. Generally, I would say 95% of the time, the calendar that we make for a medicated transfer cycle ends up being right. There are some little hiccups that can come up here and there, which might push us back by a few days, but generally 95% of the time, the transfer date is known. The intended parents, if they're from out of town, can fly in and kind of make it like a big, a nice experience for everybody. One of the other things that's always a possibility too is that the carrier, the surrogate, was already on birth control for themselves, or as their own form of contraception. So we kind of manipulate the way that they're using their birth control and kind of make it work for this transfer cycle as well. I'll finish that thought because I brought it up earlier. So the natural versus medicated transfer cycle for surrogates, the natural cycle kind of means that you're hijacking someone's own period and then transferring an embryo in where their normally released egg would then implant. The concern with that for surrogates and gestational carriers is that then they will be ovulating, and if they're sexually active, even though you're still not to have intercourse if they're sexually active, they could then transfer. They could actually fertilize their own egg, and then that leads to a slew of legal and moral and ethical dilemmas. So we avoid the natural cycle transfers for surrogates, save for extreme situations. And I haven't come across one of those yet, but the medicated transfer cycle is generally the way to go.
Thank you.
And then this question comes up, and I think more out of
Yes.
curiosity, probably, but more out of curiosity, some people, actually do want to know how many embryos they can transfer. They want twins, quote unquote. And this is kind of a hard and fast rule, I would say, by now in most fertility practices, definitely in ours. But how many embryos should we transfer? And the slide's a little bit clunky, but I'll draw your attention just to the top column there where it says the age breakdown, when it's bold. And so you'll see at any age, no matter what, if you have a euploid or normal embryo, the recommended number to transfer is one, right? We're transferring one euploid embryo. And that's because no matter how old you are, if you have a euploid embryo, your chance of live birth is about 60 to 70%. So no matter what the age was of the egg, what the time of the embryo creation. And we follow that same rule when we're talking about surrogates as well, because the goal at the end of the day, again, is healthy mom, healthy baby, healthy surrogate. And having twin gestations, although seem cute in theory, dangerous, right? They're dangerous pregnancies and they're high risk for a reason. You're seeing a high risk obstetrician for a reason because they're high risk. And so we do definitely not, we don't want to do anything that can cause harm. Of course, this goes back to our previous question that we brought up. Embryos split. A single embryo transfers do split and become twins more often in IVF than in the general population, about like 1.5% of the time. So, it definitely can happen. And so that's something to discuss with your surrogate beforehand. Is that something that they're okay with? Are they okay with carrying twins if one embryo does split?
Okay.
Mhm.
So we talked about the embryo transfer and the positive pregnancy test, assuming we get a surrogate pregnant and we're on
Mhm.
track. The next step would be purchasing life insurance. Earlier in the process, her life insurance would be analyzed. Believe it or not, there sometimes is an exclusion in your health insurance policy that says not for a surrogate pregnancy. And if that was the case, we would go ahead and purchase her life insurance at this time and health insurance if applicable. Always life insurance, I should say, and then the health insurance depending upon whether her policy has an exclusion for a surrogate pregnancy. And then around 8 to 10 weeks, they
Mhm.
graduate from the fertility clinic and begin routine OB appointments.
That's right.
So for the cost of surrogacy, I'm not going to go over each one because you can see it clearly here line by line, but I will just draw attention to some of the big ranges. So for example, the health insurance for the surrogate, if we're really lucky and she has surrogate friendly health insurance, that's why it's zero. And then it's upwards of 30,000 if we're paying out of pocket for a private policy. GC compensation, you can also see there's a wide range. And some of that goes on whether they're a first or second time surrogate, depending upon if you're working with an agency or you're going independent or with a consultant. And even within agencies, there is variation. Some will have all first time surrogates at a set fee, and second, and other agencies and independent, of course, they have the surrogate set their own fee. Also, something to think about with compensation is the cost of living in their state. So, in California, I'm
Mhm.
seeing more th- much higher than 60,000 as a matter of fact. I'm on the East Coast,
Yeah.
which is why you can see such a range. But yes, I would say in California in particular, due to the cost of living, 60,000 is honestly probably the minimum that we're seeing.
Yeah. I would agree with that.
Yeah. And there are different ways to afford surrogacy. There's grants, there's financing, there's employer benefits. Leave this, presentation is going to be recorded and sent, and you can click on some of these. Also, going to the Resolve website is incredibly helpful because you can filter by state. I didn't list any of the grants that you can only apply to depending upon which state you're a resident in, but I really encourage everybody to look at the different grants. I actually have a client, a set of intended parents right now that are recipients of the Baby Quest grant, which was really exciting. And I remember when I went through it, I didn't apply to grants because I felt so intimidated. Like, why
Mhm.
would they pick me? There's hundreds of people applying, but that's my example that you never know and you should always
Yeah,
try. And yeah, it was super exciting when we got the news a couple weeks ago. So
that's
please
great.
take a look at them and don't feel intimidated like I did in my journey. Like I please apply to them.
And it's a really good point because even like you said here, talk with HR, right? Like it's intimidating to go to your company and say, this is what I need. But there's a lot of employers now that are offering fertility benefits, but not really including surrogacy within that.
Right,
And so and I don't think it's out of malintent, it's just not on the forefront of everybody's mind. So if
right,
you go to them and you tell them, I'm a gay couple and this is what fertility means for me. This is why I'm infertile. It's just, I don't have a uterus and I don't have ovaries,
right.
like neither of us do. That might really open some doors to you. That's what my brother did with at his job, and now
Wow.
they have coverage for egg donor, for with him and his husband. So it's intimidating, but you take that leap, and what's as my mom says, what's the worst they can say? No, right?
Right.
Yeah, exactly.
That is such a mom saying, but it's really true.
Yep,
I love
exactly. As moms ourselves, we can say this now.
right.
Yeah.
Absolutely. Um, Thank you so much, everybody. It was so great to talk, and I hope this
Mhm.
presentation leaves you walking away feeling a little more empowered and knowledgeable about the journey. I'm so grateful to you, Dr. VS, for joining me with
Oh,
this and
same. Thanks,
sharing so
Jesse.
much. I feel like I always learn from you, and I really appreciate it.
Same. I feel like there's always just so much to learn about the surrogacy process, and you're so easy to talk to, which is very helpful. And I think
Thank you.
I'm sure your clients really appreciate
Thank you.
that. Do we have any questions?
I had some pre-sent to me. One person asked, and I thought this was interesting. Who decides how many embryos you need to have banked for a surrogate to proceed? The doctor, the agency, or the surrogate?
I would say the doctor. What do you think?
Yeah, and
Yeah,
I was when I was looking at this question, I was thinking about it. I was like, absolutely the doctor. And let's say there's only one. That's not
yeah,
a reason to not move forward.
yeah,
It sometimes can make matching perhaps a tad bit longer,
yeah,
but it's definitely not a reason to not move forward.
yeah. I agree with that because we can move forward and work on the surrogate while we also might be doing another IVF cycle if there's just one, and the goal is to have more, right? The one of the benefits is that the intended mother is not really tied up in the transfer process herself physically, so we can still be doing egg retrievals if we need to be to increase that number. But oftentimes it depends on what the total family building goals are. If their goal is just one child, right, and they're okay with taking it one transfer, and they have one embryo, they want to try one transfer, still, like, and sometimes we think of that 60 to 70% chance of a live birth is a low number because I'm always hoping it's 100%, and of course it's not. But 60 to 70% the chance of a live birth is actually very high, right? That's a very high percentage. The odds are in our favor. And so, thinking about that overall family building goal is going to be a really key part of that discussion. And I don't think that burden should fall on that conversation needs to fall on the agency or the surrogate, right? That's between the intended parents and their RE.
Yeah, absolutely.
Yeah.
Um, I'm taking a look at our other questions. Another one that's
Mhm.
commonly asked and was on my list of questions that I received was the average timeline of the surrogacy journey in general.
Mm.
And I think there's, yeah, a lot of variation. I think based, I know people that like, haven't identified, like they know their family member is going to carry, and we're able to just breeze through the process. And then I have
Yeah,
IPs that are with an agency that has a long wait list, and they're waiting
yeah.
for 6 to 12 months prior to beginning. So there's so much variation. So please keep that in
Yeah.
mind. I feel like 18 to 24 months is a good time frame, and hopefully we're on the closer to the 18-month mark. But I always like to prepare for the long too, so you don't feel
You
disappointed.
mean from the start of wanting to pursue surrogacy through having
Yes.
a baby in your arms?
Yes.
Yeah, yeah. That seems about right because the 10 months of that is actually the pregnancy, right? So then
Yeah.
that does make sense because there's the lead time, there's the medical clearance. And when my patients ask me that question, I often ask them, it kind of depends on you in some ways, right? As the intended parents.
Yeah.
How strict are your criteria? Because my criteria are the same, right? My criteria are the same for all of my intended parents. Your criteria may be different. Do you want somebody that lives within a 20-mile radius from you, right? And you want to go to all their appointments. And oftentimes, especially if it's someone's first journey, they do. They want to be there for the
Yeah.
whole thing. And so that really narrows down who you can choose from and who we're waiting for. So yeah, that and again, you should be picky. Like I by no means am I saying you don't need to be picky. You should be picky. If I was you, I would be very picky, as I'm sure you were as well, Jesse. So the yeah, it depends on your agency. It depends on your criteria. I try really hard to not be the bottleneck. Try to have medical records reviewed within the week that they're sent to me. Sometimes it's uh,
Wow.
sometimes it's one day if they're really short. Sometimes it's 5 days if there's extensive medical records. But we really try really hard not to be the bottleneck at CFP. So I'm
That's
getting them in
amazing.
for medical clearance and stuff. Yeah.
Yeah, and I mean, even within, agencies, there's such a difference in cost, and then,
Hmm.
going with the cost, some of the lower cost ones that, of course, then have a longer wait list because more
Sure.
intended parents are able to afford it. So there's so many different
Yep.
factors at play. It's, like, one of the most difficult questions to answer, but one of the most common ones.
Yeah. Yep.
Another question that was asked, and this is the last one, was whether embryos needed to be tested. And I don't think they're referring to, the FDA. I think they're referring to, like, the
Yeah.
PGT, for example.
Yeah. Uh, the answer to that is no. They don't need to be tested, right? That's the test answer. You're saying need to be tested. The answer to that is
Yes,
no.
like, do they have? Like,
Do
yeah, like,
you?
is it a requirement?
Would you? Should you test them? Maybe is a different answer. Yeah. So, um, I would follow the kind of the black and white answer to that is that or the textbook answer, I should say, is you should follow the PGT recommendations per the age of the egg, right? So different clinics have different practices about this. I am not a PGT for everybody is necessary type of doctor. So if somebody is young and they're 28, 30 years old, or even 34, 35 years old, that's still young in the world of genetics and egg age. So it's not necessary to have PGT. If I was transferring into you, I would not necessarily say that you need to have PGT to have these embryos tested. But that's where the caveat is, right? Like we're transferring into you versus we're transferring into a surrogate who is um like I don't want to sound crass, but like time is money and time is
Yeah,
a lot time is money and time is a lot of people's hopes and dreams as well and lives that are kind of being put on hold. So if we have failed transfers, uh, and that could lead to a miscarriage for your surrogate and then a DNC and then another saline sonogram and all of a sudden we're 4 months later. um, we could consider doing everything that we can to minimize that from happening. And so then the answer becomes much more gray. And I think more people lean towards doing PGT, which is checking just to make sure that the embryos have a normal chromosomal makeup. So we're not checking, for eye color or, any sort of specific disease, but we're checking just to make sure the chromosomes are normal. So we're already not at a disadvantage of increasing our risk of miscarriage. We could have a whole other webinar about this, Jesse. Yeah, about
yes.
PGT and the necessity of it. But the I would say that for most people, the gut instinct is that they should transfer tested embryos because they want to increase their chance of success with their first transfer, not their overall pregnancy rate. Because fine, if you don't do genetic testing, then maybe the second transfer will work. But because time is money and time is like another person's body as well, and it's not just you in the equation anymore, then I do lean towards counseling patients to do PGT.
Mhm. Yeah,
And
that makes sense.
oftentimes, even on patients, oftentimes on the surrogate match sheet, they'll say, "Will you transfer untested embryos?" And they'll say no. The
Yeah,
surrogates themselves know that they won't accept an untested embryo. So that's, that makes the decision easier for us.
right.
That's a good question. Yeah.
Yeah.
That was fun.
Thank you so much. Yeah.